All right, so today we're doing a deep dive on something I know is probably a daily encounter in your practice,
Oh, for sure.
um, dermatologic diagnosis.
Yes.
And by the end of this, hopefully, you're going to feel even more confident in, tackling all those skin mysteries that kind of walk through your door every day.
Absolutely. It's amazing how many skin conditions we see
Yeah,
in general practice.
right. And it's so interesting how so many of them, share common features. And that
Yes.
kind of makes that initial diagnosis, a bit of a head scratcher sometimes.
It can be very challenging.
Yeah, yeah. So let's start with just talking about how we can approach these cases, kind of systematically.
Okay.
Um, I'm guessing that it all begins with a good patient history,
It does. It does.
right? So what kind of questions are we asking
Sure.
to really nail down, what's causing the skin issue?
Well, we want to find out when the rash or lesion first appeared.
Okay.
How has it changed over time?
Okay.
Any associated symptoms?
Okay.
Family history. Is there anybody else in the family with a similar rash? Any occupational exposures,
Yeah.
comorbidities,
Mm,
medications?
yeah.
And then very importantly, how's this affecting the patient's life?
I like that.
Are
Yeah.
they staying home from work
Right.
or school because of this rash?
Right. Mm.
How much is this bothering them?
It's almost like, those detective shows where
Yeah.
you're looking for that, that one seemingly insignificant detail that ends up cracking the whole case wide open.
Exactly.
Right.
Exactly.
Right.
Sometimes we miss very obvious things because
So,
we don't do a full body exam.
oh, that's a good
You
point.
have to look at everything, including the scalp.
Okay.
The patient may not even know that there's something on their scalp
Right.
if we don't look.
Yeah. Yeah. Good point. All right. So full body exam. Got it.
Even the scalp.
Even the scalp. Okay.
Yeah.
But then, even after you've gotten a thorough history
Yes.
and you've done that full body exam,
Yep.
sometimes, all these lesions, they kind of look the same.
Right.
So how do we start to differentiate?
We have to train ourselves to really look at the morphology of the lesions.
Okay.
Are they flat?
Hmm.
Are they raised? What's the shape?
Yeah.
What's the color?
Okay.
How are they distributed on the body?
Right. So we're looking for patterns, just like, the detective at a crime scene.
That's exactly right.
Right.
It
Yep.
it is about pattern.
Right. So talk to me about that.
Yeah, sometimes we see these dermatologists and they make diagnoses in 10 seconds
Yeah.
and we're like, how did they do that?
Right. Yeah.
It's like magic, right?
Yeah. Yeah.
It's not magic.
Okay.
What they're doing is breaking down their observations into different categories,
Hmm.
and we can do that too.
Okay.
So the way we break down these lesions is to think of them as primary lesions
Okay.
and secondary lesions.
Okay. I've heard those terms before. But a little reminder, I think, would be helpful.
Yeah.
What are primary lesions versus secondary lesions?
So primary lesions are the initial reaction of the skin
Okay.
to whatever's causing the problem.
Okay.
So they're like the first brushstrokes on the canvas.
Okay.
Secondary lesions develop over time
Okay.
due to scratching, rubbing, infection,
Right.
or healing.
Okay.
So they change the picture. They add complexity to the original lesion.
Got it. So primary lesions are our original suspects,
Yes.
and then secondary lesions are the accomplices that come along and muddy the waters a little bit.
Exactly.
Okay.
That's a great analogy.
So let's focus on some of the most common primary lesions
Sure.
that we're going to see in our practices. I mean, I would say
Mm-hmm.
probably macules and papules
Yes. Macules and papules.
are kind of like the bread and butter of dermatology.
Absolutely.
Right. But those are the ones that trip me up. What's the difference again? How I remember the difference between those two?
So the way to remember it is a macule is flat,
Okay.
like a freckle.
All right.
A papule is raised
Okay.
and palpable,
Okay.
like a small wart.
So if I can feel it,
Yeah.
it's a papule.
Yes.
If it's flat, it's a macule.
Yes.
Got it. Okay.
Good.
But there's so many different other kinds of lesions out there.
There are.
How do we keep them all straight?
Well, the truth is you don't have to memorize every single type of lesion,
Okay.
but there are a few that are very common.
Okay.
And so plaques are larger raised areas of skin, often formed by a bunch of papules joining forces.
Okay.
Nodules
Yeah.
are deeper
Okay.
and firmer bumps.
Mm-hmm.
They extend into the lower layers of the skin.
Okay. So plaques and nodules,
Mhm.
I'm already seeing that,
Yes.
size,
Yes.
and whether it's flat or raised.
Right.
Are those key things to pay attention to?
Absolutely.
Yeah.
And then we have things like vesicles, which
Mm-hmm.
are small, fluid-filled blisters,
Okay.
pustules, which are pus-filled bumps.
Right.
We all remember those from our teenage years.
I was just going to say,
Right.
the bane of adolescence,
Exactly.
pustules.
Pustules.
Okay, but what about if a patient has darker skin?
That's a very important point
Right.
because when we're examining patients with Fitzpatrick skin types, Y beta
Mm.
6, things may look different.
Okay.
So inflammation may not show up as redness
Oh, wow.
in a darker skinned patient.
So it's those subtle variations in color then
Exactly.
that we have to be extra attentive to.
You got it.
Right.
We're looking at changes in pigmentation,
Mm-hmm.
texture,
Okay.
and the way the light reflects off the skin.
Wow. I'm realizing there is so much more to dermatologic diagnosis
There
than I
is.
think I even realized.
It's a fascinating field.
Yeah.
It really is.
Okay. This is great.
Okay.
But I know there's more to come.
There is.
Right. What are all those fancy tools? We haven't even talked about things like dermoscopy.
Yeah, we'll get to that in the next part of our deep dive.
Okay.
We're going to talk about how those tools can really help us see beyond the surface
Right?
and unlock even more clues about these skin conditions.
I can't wait.
Okay, great.
This is fascinating.
Good, I'm glad.
I'm loving this.
Right.
Okay, so everybody stick around. We're going to be right back
It sounds good.
after a quick break.
Okay.
Okay, so we're back, and I'm already starting to feel a little more confident about tackling these dermatology cases.
Good.
But you mentioned some special tools.
Yes.
Those things that can help us to kind of see beyond what our naked eye can catch.
Yes, you're talking about the Woods lamp and dermoscopy.
Right, exactly.
Yes.
But I'll admit, I haven't used these much in my own practice.
Okay.
So can you break down for us when and how these are actually helpful?
Sure. So the Woods lamp is an ultraviolet light, and it helps us see things that are not visible under normal light.
Okay.
So it's particularly useful for things like vitiligo,
Okay.
where those depigmented patches really stand out under the Woods lamp.
So it's like shining a spotlight
Exactly.
on those subtle color variations.
You got it.
Okay. And what about dermoscopy?
So dermoscopy is like a high-powered magnifying glass,
Okay.
but it does more than just make things bigger.
Okay.
It allows us to see structures beneath the surface of the skin.
Wow.
So it's like having a microscopic window
really
into the epidermis and even the upper dermis.
So we're literally seeing beneath the surface of the skin.
Yes.
That's incredible. So when would we actually use that, in a general practice setting?
So one of the most common uses is to evaluate pigmented lesions, like
Yeah.
moles.
Okay.
And with dermoscopy, you can actually see the features much more clearly
Okay.
and determine if a lesion needs further investigation.
That's so helpful, especially with, skin cancer being such a concern.
Exactly.
It's almost like having an early warning system, right?
It is. It
Yeah.
is.
Okay.
And dermoscopy is not just for pigmented lesions.
Okay.
It can also be helpful for inflammatory conditions
Okay.
like psoriasis and eczema
Yeah.
and even parasitic infections like scabies.
Wow. So it really is a versatile tool.
It is.
But I'm guessing there's a bit of a learning curve.
There is a learning curve.
Right.
It takes practice
Okay.
to interpret the dermoscopic images
Right.
correctly.
So it's like learning a new language.
It is. It is.
But it sounds like it's a language worth learning.
It is.
Okay, I'm convinced. I'm gonna go look at some of those online tutorials that you mentioned earlier.
I think that's a great idea.
Okay, so we've talked about, history,
Yeah.
Zam,
Yes.
the special tools.
Yes.
But what about the bigger picture here?
Okay.
How do these lesions actually arrange themselves on the body?
That's a great question. So the distribution of skin lesions can give us a lot of information about the underlying cause.
All right.
So we call these distribution patterns,
Right.
and they're like a secret code
Oh, a secret code.
waiting to be deciphered.
Okay, I'm intrigued. Tell me more.
So for example, if you see lesions that are clustered together
Mm-hmm.
in a small area,
Okay.
that might suggest something like herpes simplex.
Okay. Clustered lesions,
Yeah.
herpes simplex. Or what about if they're, more spread out,
Okay.
but still kind of grouped together?
So then you might be thinking about things like dermatitis crepitiformis
Okay.
or granuloma annulare.
Okay.
Those tend to form grouped patterns.
Grouped patterns,
Yeah.
dermatitis herpetiformis,
Right.
or granuloma annulare.
Uh-huh.
Okay, got it. What if they're all lined up, in a row?
So that linear pattern could point to contact dermatitis,
Okay.
especially if it follows the line of contact with an irritant,
Ah,
or it could be morphea,
okay.
which often presents with these linear bands of thickened skin.
Linear pattern, contact dermatitis or morphea.
Yeah.
This is starting to feel like a dermatology puzzle. I'm kind of loving
It's
this.
good. It is.
Okay, what about those rashes that kind of only appear on one side of the body,
Right.
like they're following a nerve?
So that's called the zoster pattern.
Okay.
And that's classic for herpes zoster or shingles. It
Okay.
follows the path of the affected nerve.
Zostriform pattern shingles.
Yeah.
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 I remember that one. Are there any other patterns that we should be on the lookout for?
So one more important pattern is coalescing lesions.
Okay.
So these are lesions that start out as separate spots, but
Mm.
then they merge together to form larger patches,
Okay.
like in psoriasis,
Right.
where you see those plaques expanding and sometimes joining together.
Coalescing lesions, psoriasis. Okay.
Yes.
So I think I've got the major patterns down now.
Okay.
We've got clustered, grouped, linear, zostriform, and coalescing.
Good.
It's amazing how much information is just, right there.
I know. It is
In
amazing.
plain sight. We just got to learn how to recognize it.
Exactly. And the best part is that these patterns, when combined with all the other information,
Right.
the history, the morphology, the special tests,
Right.
it all comes together to give us a clearer picture of what's going on.
So it's all about connecting the dots.
It is. It is.
Looking for those key pieces of information that fit together to reveal the bigger picture.
Absolutely.
Okay, I'm starting to feel like a real dermatology detective here.
That's great. That's what we want.
This is good.
Good.
Wow, we've really covered a lot in this deep dive.
We have.
Everything from those basic lesion morphology all the way to those high-tech tools and those fascinating distribution patterns. It's really like unlocking a whole new level of understanding.
I agree.
So in this final part,
Yeah.
let's talk about how we actually bring all of this information together
Okay.
and confidently approach these dermatologic diagnoses in our practices.
Sounds good.
I'm ready to put on my detective hat and solve some skin mysteries.
All right. Well, just like a good detective, we have to carefully examine all the evidence.
Right.
And that means taking a good history,
Mm.
doing a thorough exam,
Yep.
considering all the factors we've discussed.
Right. It's all about connecting those dots, right?
Yeah.
Looking for those key pieces of information that fit together to kind of reveal that bigger picture.
Absolutely. So let's say a patient comes in with itchy, red, scaly patches on their elbows and knees.
Okay.
And you learn from the history that these patches come and go.
Mm-hmm.
They often flare up during times of stress.
Okay.
And on exam, you see well-defined plaques with silvery scales.
Uh-huh.
You check the scalp and you find similar lesions there.
Okay, so based on what we've already talked about, this is sounding a lot like psoriasis.
It does sound like psoriasis,
Right.
but we don't want to jump to conclusion.
Right.
We have to consider other possibilities.
Right.
Could it be eczema?
Hmm.
Could it be seborrheic dermatitis? So that's where those subtle clues become so important.
So we're playing a game of dermatologic elimination,
Exactly.
ruling out those suspects one by one
Exactly.
until we get to the right answer.
Right, and sometimes we need additional tests,
Okay.
like a skin biopsy, to
Okay.
confirm our suspicion.
Like calling in the forensics team
Exactly.
to analyze the evidence.
Exactly.
All right, so let's shift gears just a little bit
Okay.
and talk about some practical tips for managing some of these, really common skin conditions.
Sure.
We see in our practices all the time. Let's start with eczema.
Okay.
That's when I see constantly.
Yes.
And it can be so frustrating for patients, especially those who have chronic eczema.
It is.
So what are some of the key things to keep in mind when we're managing these cases?
Well, I think first and foremost, we need to educate our patients
Okay.
about the chronic nature of the condition
Uh-huh.
and the importance of good skin care. Gentle cleansing, regular moisturizing, and avoiding triggers that can exacerbate the symptoms.
So it's all about empowering them to really take control of their own skin health.
Absolutely.
Okay.
And then when it comes to treatment, we have a variety of options, from topical corticosteroids
Mm-hmm.
to newer therapies like topical calcineurin inhibitors,
Right.
and even systemic medications for patients with severe disease.
It's nice to have so many tools in our arsenal.
It is.
Okay, so what about acne?
Okay.
That's another one that can really impact a patient's quality of life,
Absolutely.
especially teenagers.
Especially teenagers.
So how do we approach that?
So with acne, it's all about understanding the underlying cause
Okay.
and tailoring the treatment accordingly.
Okay.
So we might use topical retinoids to unclog the pores,
Mm,
benzoyl peroxide to kill bacteria,
right.
or even oral antibiotics for more severe cases.
And of course, we can't forget about those hormonal fluctuations,
Right.
especially in women.
Especially in women.
That often play a role,
Absolutely.
right? So sometimes we need to consider those hormonal therapies,
We do.
like oral contraceptives
Yeah.
or spironolactone,
Yes.
to kind of address those imbalances.
Exactly.
This is so helpful.
Good.
Any other pearls of wisdom you want to share before we wrap up?
Well, I just want to remind everyone that you don't have to be a dermatologist
Right.
to provide excellent care for your patients with skin conditions.
Yeah.
If you use a systematic approach,
Mm-hmm.
hone your observation skills,
Yep.
and stay up to date on the latest treatment options,
Right.
you can make a real difference in their lives.
This deep dive has been amazing.
It has.
I mean, it's incredible how much we've covered
I know.
in such a short amount of time.
It's a lot of information.
Yeah, I feel more confident, I feel more knowledgeable, and I feel ready to tackle those dermatology challenges head on.
That's great.
So, listeners, we hope you've enjoyed this deep dive into the world of dermatologic diagnosis and management.
It's been fun.
Remember that systematic approach, that keen eye for detail,
Yes.
and the willingness to learn. Those are your greatest assets
I agree.
in this fascinating field.
Absolutely.
Keep those diagnostic skills sharp and never stop exploring.
Never stop learning.
All right, everyone. That's it for this deep dive.
Okay, great.